Dear colleagues, thank you for the invitation to speak about robotic surgery and special hernia cases in this very interesting form of conference. To the beginning, some facts about me. I like hernia surgery and particular, I like new inspiring methods. So I'm using laparoscopic IPOM since 2003, the different methods of component separation techniques since 2010, and I started robotic surgery at the end of 2018. Robotic surgery has become an increasing influence in the general surgery during the last years, but it seems we have still more questions than answers. It's like the black hole in the space. We know it exists, it is fascinating, but we don't really know what the benefit of it is. As with any other new methods, we must ask, what do we expect from robotic surgery? We are in expectation of even less of pain, of tissue damage and complications, furthermore a faster recovery and a better post-operatively outcome, and we hope of a lower recurrence rate, especially in hernia surgery. What do we actually know about robotic surgery? At first, the need of a long learning curve and a high volume case series. Actually, we have only similar comparing results in the colorectal surgery shown by the roller study last year. We have high costs in purchase, we have high costs for the special instruments, and we have high costs for the maintenance. Especially in Germany, we have an economic problem because there's no adequate reimbursement in the DRG system. When do we need the robotic surgery? We need it in addition to the technical limitations of laparoscopy with advantage of high definition, three-dimensional visualization close to the object, multiple degrees of freedom of the robotic wrists, and a superior ergonomics. So robotic makes working in small spaces with difficult and expensive preparation really easier. Concerning hernia surgery, we have good data in any single center case series, for example by Balasser, Carbonell, and Philip Musems. Of course, the industry wants to increase the use of the robotic approach in hernia surgery, and for example, here this supported comparative analysis of robotic versus open transversus release. There are only short-term data published, and the author's conclusion are robotic-assisted surgery was associated with decreased intraoperative blood loss and systemic complications, but there were no data about recurrence rate or long-time complications. To find out actual opinion in Germany, I did a survey by all certificated hernia centers in Germany, Austria, and Switzerland, as well as by some hernia experts in these countries. Unfortunately, the feedback was very low. Only 44 of 113 colleagues were answering. Nevertheless, I want to present the results. Only 13 of 44 colleagues using the robot. Only 5 of this 31 other planned in purchase in the next time. All 13 users performing colorectal surgery, but only 5 of these 13 using the robot for incisional hernia repair, and the 8 others don't see an advantage for the robot in hernia surgery. I know it is the current status. In the near future, we will get new devices, new robotic systems, perhaps this new possibilities changing the actual meaning. Currently appears that this special method is only performed by individual surgeons. Under the aspect of loss of domain hernias as a part of complex hernias, we have differentiate to decide case by case about the use of robotic. So that's our own data by incisional hernia surgery in the last years. We have done 4 robotic TAR operations in 2018 and 8 in 2019. Now we have a big problem with our clinic management about the reimbursement, so we had to reduce using the robot in hernia surgery. At the end, I want to demonstrate one case from September this year. It is a loss of domain iliacal hernia on the right side after a partial resection of the iliacal crest for mandibular reconstruction. The patient's risk factors were a BMI higher 35%, diabetes, or in COLD. So here are the CT scans of the female patient. We started the laparoscopic reposition with using the 8mm ports of the robot. Then we carry out the TAR and covered the defect with a 30 x 30 cm mesh. The fascia was closed with a running non-resorbable suture. The problem we had was a large hernia sac with massive skin excess, so additionally we need an abdominoplasty. What is my opinion in the moment, knowing the present data and our own experiences? Robotic is a good option for unilateral TAR and for hernias in special localizations like subcostal, lumbar, iliacal, or parastomal. It's also in my mind a good option in cases of loss of domain if a trouble-free reposition is possible. And the robotic is an addition to the open or endoscopic supply techniques. Robotic in my mind is no option for loss of domain hernias with a risk of resection of gut, no option in cases with insufficient closure of the midline, no option in patients with skin defects, atrophic skin areas, and no option for patients with enterocutaneous fistulas. With all the possible enthusiasm in robotic surgery, please don't forget, sometimes we need an open approach. So I finished my topic. I wish you all the best and I hope we see us in real life next year. Best regards from Leipzig. Bye.